pleasure today to talk with my friend and colleague Kevin Bainey about the evolution of STEMI care, both on the clinical side and on the academic side, that came out of really the Edmonton environment and the CBC Center. I'll start off with a little bit of rapid history. We really questioned the ability to take treatment to patients, in essence, activating our ambulance colleagues way back in 1999, and proved that a Canadian paramedic-based system with good physician oversight was actually as effective as physicians in the ambulance in Europe in treating STEMI. It took us through a journey to West, a Canadian collaborative study testing a pharmacoinvasive approach versus standard lysis and standard care, or primary PCI. And it really set the stage for the pharmacoinvasive strategy, which we studied more extensively in STREAM and proved that it was at least as good as primary PCI. And if you play with the stats a little bit, there was a 91% chance it was actually better. So it didn't meet the classic p-value, but in perspective. And it led us through a journey of a lot of important work and implementation of a clinical program based on those strategies back in 2006. So for 16 years, we've been implementing and running the pharmacoinvasive approach. So Kevin, like, you've had this opportunity to work through all of this time and collaborate on the clinical front, but also lead a lot of the research on the registry. So maybe give us some highlights.
Yeah, thanks, Rob. So, we were fortunate enough through the work with CBC to be able to look at our own vital heart response registry, which, you created, and looked at all of the STEMI patients over a period of time and collected their ECGs. So my role with CBC is ECG Core Lab Director. And the ECG component to this study was quite profound. So we took a step back, looked at the results of STREAM and said, okay, let's see what our registry data shows in terms of a pharmacoinvasive versus primary PCI approach to STEMI. And we looked at over 5,500 patients in Northern Alberta. And again, assessed core lab ECGs. And from an ECG standpoint, there was improved ST segment resolution with a pharmacoinvasive approach versus primary PCI. That was quite profound to start with. But that actually also translated towards an improvement in clinical outcome. Now, we looked at death, shock, heart failure, and re-MI at 1 year, a similar composite to STREAM. And interestingly, in our registry data, we actually showed improvement in clinical outcome with a pharmacoinvasive approach versus primary PCI, and did many adjustments to show that clinical benefit. And it really does speak to our program in that we do strongly endorse and believe in a pharmacoinvasive approach. But what was also interesting in this registry analysis is we looked at the patients that got half dose TNK. And as you can recall from STREAM 1, there was an amendment that was made in which elderly patients over the age of 75 had a modified half-dose regimen. And in STREAM 1, it appeared to be working well with that and mitigating that bleeding risk. So we looked at it in our registry, and again, it was quite profound. It was safe, and it appeared that the STs were coming down, and clinical outcomes were just as good as primary PCI. So really begged the question moving forward in the spectrum of STEMI research is, we know pharmacoinvasive approach is just as good as primary PCI, arguably better in our registry analysis. Where does the half dose story fit in? And as you know, STREAM 2 has been designed, is currently enrolling and well underway, testing this concept of half dose pharmacoinvasive approach versus primary PCI. And maybe, Rob, you might want to highlight some of the ongoing efforts that are being done with STREAM 2.
Yeah, STREAM 2 is a really important next step for the pharmacoinvasive strategy. If we can sustain all of the efficacy, which we believe to date, the signals tell us we can, and enhance the safety, it will really be another step forward. And the registry work, you highlighted the biggest and the most important, but there was the aborted MI work, the many papers that have come out of that. So I guess, as we think about next steps and where we're heading, there are some really neat collaborative opportunities that we're both pursuing together and also separately with different groups, really using pragmatic data sets. So one of those is the doxycycline storyline, which started at the University of Alberta Bench Research with Richard Schultz, where he really did the animal models to prove that you decrease infarct size with a simple drug like doxycycline. So that study's going along well, but you're also leading another one called sonolysis. Just tell the group a bit about that before we close out.
Yeah, no, that's super exciting. And a lot of this, our ongoing STEMI studies are based on our robust ECG core lab that we have, which we're fortunate enough to have core lab ST segment analysis. And so, we're testing this concept currently of sonolysis, which is, augmented ultrasound impulses at the time of STEMI, to see whether or not we can break open some of this thrombus and improve the ST segments, and hopefully then translates towards an improvement in clinical outcome. We looked at about 15 patients already and have published that recently in the setting of primary PCI, showing that this therapy appears to be feasible to do. But we've taken a step beyond now and are involved in a randomized study called STEMI-lysis, which is randomizing patients in a 2-to-1 fashion to a pharmacoinvasive approach randomized to giving sonolysis versus standard of care, in the hopes that in the setting of administering fibrinolysis, that sonolysis itself will augment ST segment resolution, improve reperfusion, and hopefully mitigate the number of cases that have to go on to rescue intervention. So an exciting stage for STEMI, and I think more to come, particularly with the pre-hospital setup that you've developed in Edmonton.
Yeah, and as we head to close, I would like to acknowledge that our clinical program and the collaboration in the zone with our colleagues across Edmonton has been key. And that model has really now been implemented in other places and is being, in essence, copied and applied elsewhere. The most notable being Mexico City, where they've actually set up a large network that's very similar to our existing one, using the same strategies of pharmacoinvasive approach and PCI when appropriate. So very exciting times to see both the clinical and the research side continue to succeed and grow.
Yeah, super exciting, and I think a bright future moving ahead.
All right. Well, thanks very much, Kevin. It's been great. And for anyone you listening, if you want to reach out to either one of us, we'd always be happy to talk through these stories with you. So thanks again.
Thank you.